We are continuing now with our plenary lecture, and I will shortly speak in English and then in Serbian. It's my pleasure to introduce Andrea Raballo, professor of psychiatry and our dear colleague, who will take us to the, I think, very interesting and intriguing trip into the galaxy of early psychotic disorders. Andrea, I will go to Serbia now. Andrea Raballo je profesor psihijatrije koji nam dolazi originalno iz Italije, ali je u ovom trenutku na poziciji redovnog profesora na univerzitetu, na švajcarsko-italijanskom univerzitetu u Luganu. Inače, njegova karijera počinje od kada je dobio stipendiju Marie Curie i kada se našao u skandinavskim zemljama, bio je i u Danskoj, bio je i u Norveškoj i gde je intenzivno radio na proučavanju, u stvari, psihopatologije psihotičnih poremećaja. Mi smo juče imali jedan kratak kurs koji je on vodio i ja zaista stičem utisak sada da nikada nisam bila pored boljeg poznavaoca psihopatologije nego što je to Andrea. Dakle, radeći sa Jozefom Parnasom, između ostalog, kao jednim od najvećih imena trenutno kada su u pitanju poremećaj ega, poremećaj selfa, Andrea je dosta toga stekao da bi mogao da bolje prepoznaje različite probleme u tranzicionom periodu adolescencije u adultno doba. Njegova pozicija je jedno vreme bila u univerzitetu u Peruđi, a sada je prešao i on je u stvari akademski direktor, znači direktor za postdiplomsku i dodiplomsku edukaciju u psihijatriji na ovom univerzitetu. Andrea ima preko 160 publikacija na PubMedu, koliko bi googlovali u ovom trenutku, njegov Hirschov indeks je 36 i ja mislim da imamo pred sobom zaista jedinstvenu priliku da čujemo nekoga ko je izuzetno mnogo radio, ne kao istraživač prvenstveno, nego prvenstveno kao kliničar u oblasti stanja povišenog rizika za psihozu i svih adolescentnih, kriznih i nejasnih stanja. So, I finished my introduction and it's my pleasure now, and please, the floor is yours.
Well, thank you, Nadia. I have to say that I couldn't follow the talk, but it was fantastic to hear it in Serbian, so it was a pleasure. And my presentation is entitled in this sort of bizarre way, Game of Transition, because it's a polysemic term. It has become something very fashionable in the literature, but it embodies a multiplicity of layers. And I would like you to think about the presentation that Bruno gave yesterday with all this sort of infrastructure of myth, because this is what is at stake basically in this very field, which in my view is somehow quite symptomatic of the current trend in psychiatry as a general field. And then I think it's a kind of galaxy because it's a lot of concept, satellite structures, and many ways in which they are framed, even if we are mostly exposed to a sort of mainstream discourse. Anyhow, in psychiatry, we do not only have sort of transition towards psychosis, we have several levels in which transition is important. The classical one is a psychopathological change of mental state. Let's say that on a clinical level, the most immediate example is when you move from being an help seeker into somebody who is really in need of care beyond that moment of assessment, so clinical caseness. Then we have a nosographic transition from pre-nosographic status, when you are below the threshold of a diagnosis and you become flamboyantly symptomatic. Then we have developmental transitions, which are apparently age-related, but anyhow they require a sort of biopsychosocial readaptation of the person, which is normally physiological, but sometimes it can deviate and enter into psychopathology. Then we have institutional transition, that they are sort of bureaucratically addressed as continuity of care. And then we have the sort of AUKUS concept. AUKUS, it's the sort of trilateral agreement, Australia, UK, US, which is this idea that you can predict psychosis looking at attenuated psychosis, which is a bit tautological, but that's the way it goes. All this polysemic transition, they anyhow end up to create emergent themes in the literature, and typically after 10 years they become daily practice in the clinic. Key issues are continuity of care, this new entity called transition psychiatry, which is supposed to be a sort of bridge between adolescent and youth mental health. So let's say from 14 to 25 years old. Then you have the broad field of youth mental health, which is sort of relatively new, but it's quite relevant in terms of health policy. And then you have this fantastic term, which I love, it's precision psychiatry. I mean, I'm used every 3 or 4 years to have new adjective associated to psychiatry, patient-centered psychiatry, personalized psychiatry, and so on and so forth. And I mean, to me, they're not even emergent themes, they are just bibliometric attractors, basically, or bibliometric enhancers. Nonetheless, they have a sort of implicit paradigmatic effect, so they change the way we relate to our patient, to our discipline, even if we are not fully aware of that. Now, the issue of transition to psychosis is something quite old. It's 3 decades. So basically from, I don't know if you saw it when it was released in the US, it was 1994. So you have George Clooney, still with not white hairs, and in Italian it was translated in ER Medicine Prima Linea, which would sound like emergency room, doctors in the trench. And across the years, we ended up having Netflix. So that's the anthropological change we underwent in these 30 years on a sort of mass culture, which means that we had several generations of professionals, not only psychiatrists, but psychologists, nurses, educators, rehabilitation technicians, and so on and so forth, who entered in the field and changed their own mentality, being exposed to different cultural environments. And that's the starting point of the Big Bang. It was a conference in Norway in 1994, and that was the sort of icastic presentation at the time. So there was this sort of blinkers or blinders of the horse, and the idea that clinician had a sort of very partial and parcellar view of reality, only focusing on major psychopathological condition and forgetting that they are preceded by reality, which means what happens before you become fully symptomatic to the level of the DSM or ICD. And this is a paper of 2005, which I love because it's very smart. It's not very much quoted as usual, but it's very subtle. And it's an adolescent psychiatrist from the US who says, well, we try to look at the psychosis prodrome in adolescents through the prism of DSM-4. And this is what they found, and this is basically the reason of all this emphasis on at-risk mental states. The initial prodrome, or the period preceding the first episode of psychotic illness, is characterized by the gradual emergence of non-specific symptoms that present significant diagnostic dilemmas, and they cause frustration to the patient and to the family. You know, that's very sort of immediate reality testing of what was the situation about 20 years ago, 15 years ago. So there is a diagnostic gray zone. The DSM-4 does not offer a clear framework for describing the widespread subthreshold symptomatology that characterize putatively prodromal patients. Now, it seems banal, but at the time it wasn't. Because somehow, you know, within the Anglo-American culture, which is the sort of generating environment of the DSM, they somehow realized that the categories that they have been using up to that moment, Axis 1, Axis 2, and so on, were not nuanced enough to capture a lot of presentations, typically in developmental years, which were clinically subthreshold in terms of intensity of symptoms, but in full need of care. So there was this sort of, you know, alarm in Australia, in US, and UK. But what had happened in meanwhile? Well, first of all, as a sort of macroscopic change, there was a modification of the notion of schizophrenia, which took a century, but it's not by chance that in the 90s there was a sort of contraction of the descriptive feature of schizophrenia, and they were somehow shifted even more towards positive symptoms, so the psychotic part of the symptomatology. Then there was this notion of early and broadly defined psychosis risk mental states, which is it's a sort of lapsus, you know, they speak about psychosis, but then the outcome is either other psychopathology or schizophrenia. And schizophrenia is not only symbolized by the psychotic part, because it is a spectrum and you have a lot of conditions that do not generate delusional hallucination, but nonetheless they are within the schizophrenia area, and that's well known since Bleuler. And this is the other big change that happened in the field without being tracked that explicitly. And this is a synthesis by Insel. You know Insel, it's fantastic. He was the head of NIH in the US, and then he moved to Google to develop digital phenotype, and then Google was not innovative enough, so he founded his own company. But for about 2 decades, he was the only one who could foresee the future, because he was sitting in the top position to evaluate grant applications in the US. What did he say? Well, perhaps the most fundamental change in reconceptualizing schizophrenia is the neurodevelopmental aspect, which is not that new, but the notion of trajectory of illness. That's a little bit more appealing. And then, it's a detail, but it's quite important. The psychosis of late adolescence must be seen not as the onset, but as a late stage of the disorder. So it is phenotypically, diagnostically early, but is sort of developmentally and putatively neurobiologically quite advanced, even if we are talking about developmental years. These are all the sort of macroscopic, yet not necessarily explicit changes in the field that surround the issue of transition. But, to be honest, this is an evergreen clinical core problem. Since the days of Kraepelin and Bleuler, clinicians have noted the existence of certain precursor symptoms in patients that later were found to suffer from schizophrenic psychosis. Look at what Kraepelin wrote more than a century ago. The onset of mental illness is generally a gradual one. Far rarely the disorder befalls the human all of the sudden without any precursor. The development of the disease, ailment that is the meaning, can last years and even decades if no vigorous forces of circumstances in the struggle for existence speeds up the outbreak. That's even an anticipation of the vulnerability stress model. The onset of illness frequently ties with certain ages, first and foremost, the developmental years. That's not McGorry, it is Emil Kraepelin. And the interesting thing, if you think about it, even the sort of hyper-stigmatized notion of dementia praecox, the important thing is not dementia, it is praecox. So the fact that this kind of syndromic entity happened in developmental years, that was the sort of inbuilt core component of this new entity of the last century, which then was termed schizophrenia. So the developmental part was inbuilt in the concept, even if we somehow rediscover the wheel every couple of decades. And this is fascinating, because all this happened because of a big conceptual blind spot. So, the people, and basically all the sort of psychiatric community that was educated under the DSM ended up losing the vision of certain pathways of psychopathology that were familiar to any clinician before the sort of widespread diffusion of the operational criteria. Because at a certain point, the operational criteria, which were supposed to be a facilitator, they became some sort of glossary of psychopathology, which they were not supposed to be. So you have the American child adolescent psychiatrist Myers saying, well, the DSM-4 descriptors are insufficient to characterize this kind of patient, which were fully characterized by Bleuler and Kraepelin without precision psychiatry. So the contemporary mainstream AUKUS approach, it's AUKUS because it actually started in Australia, then it was copy-pasted in UK, and then filtered in the US, and then came back again around the globe. It's the so-called early intervention paradigm, which has a lot of advantages. The first one being that it's quite pragmatic, and it can be an important accelerator of progress in many contexts that are too much focused on the management of chronicity. But on a sort of conceptual level, it's quite simple. They had the problem of symptomatic help seeking. The symptomatic help seeking was below the threshold of the DSM-4 diagnosis. In the DSM-5, you know that they have created this new category, which is a sort of copy-pasting of one of these clinical risk criteria that we are going to see. And this help seeker had attenuated psychopathology. What does it mean? That in a scale from 1 to 10, you have a delusion which is about 5 instead of having it 8 or 9. You have a sort of depression which is about 6 and not 9, and so on and so forth. And then they created the concept of at-risk mental state, which is a sort of replacement of the prodromal concept, because the idea was that the notion of prodrome is retrospective. So you have a clinical case, and then retrospectively you find out what was the precursor condition, and somehow there is some sort of implicit prejudice of determinism. Whereas in the notion of at-risk mental state, you have a prospective view. So you are supposed to intercept the help seeker before he or she develops an Axis 1 disorder, because that was the conceptual framework at the time, DSM-4. And then out of this probabilistic cloud of risk, they extrapolated a subgroup that was vigorously in imminent risk of becoming psychotic, meaning that they would have had the risk of flamboyant hallucination and or delusions. So a first episode of psychosis a la DSM-4. What is AUKUS psychosis? What's the concept that was behind all of that? Two things. Operational definition, threshold at which neuroleptic, you see, it's many years ago, they don't even call it antipsychotics neuroleptic, which conveys, at least in the sort of common sense koine, a feeling of antiquarial denomination. Neuroleptic medication would be commenced in common clinical practice. You know, this is pragmatic definition, but it is quite unlikely that the same patient in two different community mental health would have exactly the same threshold, unless they are super severe. And the equivalent is clear-cut psychotic symptom, namely delusions, hallucination, formal thought disorder. Then formal thought disorder got lost because basically unless you're super trained or somebody's really crazy, you don't get it because it's very subtle usually in these phases. Occurring several times per week for at least 1 week in a help-seeking population, which, you know, it's a lot of information condensed to put a sort of equivalence to what it is like, what the mental state of the person that you would treat with a neuroleptic in a conventional setting is. And this is, you know, I'm doing this sort of archaeology because these are the quotes of the people in Melbourne that coined the central notions, and it's important that we are clear on where the central notion came out, not only geographically, but clinically speaking. Because we are exposed to this sort of short memory process every time, so one forgets from where the concept comes from. So what is a prodromal or at-risk mental state? By the Australian definition, 1996, it is a process involving changes in experience and behavior over time, rather than a simple list of symptoms at any one point. So it is a process, but how do they try to capture the process? With the same recipe of the DSM that was sort of a blinding feature for them. Namely, they create operational criteria. The concept was called ultra high risk, then it became clinical high risk, and then clinical high risk was replaced by clinical high risk P, which means psychosis. But anyhow, it's the same concept. It's like the ring of the Lord of the Rings, you know, a concept to rule them all. The operational criteria not only indicate a need for immediate clinical care, so there is the sort of help-seeking part with need of care, but they strongly predict imminent transition to psychotic disorder. Again, psychotic disorder for them, it's delusions and hallucinations. And the category to predict that are BLIPS. It's all acronyms, you know. It's funny because it's all acronyms. BLIPS means brief, limited, intermittent psychosis, meaning you have psychotic symptoms, but they have a relatively short duration, so they last then 1 week. So it is 6 days, you are just at risk, you're not in first episode of psychosis. It is true, it is like that. Or they can be APS, attenuated psychotic symptoms, so they can last for longer, but their severity is a little bit below the threshold that is required for the DSM-4 diagnosis of schizophrenia. Or, and that's the way they sort of try to incorporate the line of family high risk, you need to have a first degree relative with a clear diagnosis of psychosis, or you have to have a schizotypal personality disorder and a decline in functioning. Frankly, in the AUKUS literature, the group BLIPS and the group of the family high risk, it's underrepresented. So they basically 95% of their samples are only APS, attenuated patient. In my sort of daily experience in Italy in community mental health, the people with family high risk were about the 20%, which is quite interesting because if you transplant the transition rate from Australia into other countries, they might not match simply because the system, it's different. And to be honest, I mean, we know by at least 1.5 centuries that there is a family risk going on. So it is quite implausible that this population, if you have an efficient mental health system, is so underrepresented. I mean, the population of those with some relative or some sibling that is already under some form of psychological or psychopharmacological help. So, from Kraepelin to McGorry, what has changed? because at the end of the day, they were both focusing on adolescents. They are both focusing on adolescents. Let's say Kraepelin is even more left-wing because he says, well, it's vulnerability and stress. It's not only the age and the symptoms. And anyhow, everything, it's very early in development, meaning that it typically happens before 18. Well, we had explicit semantic change. So we moved from the stigmatized concept of prodrome to the more fashionable, perspectival risk attractor that is at risk mental state. We had an attenuated syndrome, which is the one that was copy-pasted from the criteria into the DSM-5, because we have an attenuated psychosis syndrome, which is sort of chapter 3 DSM-5 diagnosis, which is just, it's a metonymic operation. They took one of the criteria, the most representative one and the most dull, and they put it as a sort of precursor of full-blown psychosis. And the funny thing is that everything was modeled, because McGorry says it explicitly, they took the diagnosis of the paranoid schizophrenia and they considered a sort of hyposchizophrenia, so a mild version of schizophrenia. That was the way they created the criteria at the beginning. And then they developed it in the clinical staging, which is interesting, and we might discuss about it. And then they ended up with this concept, I mean the AUKUS, but the concept in itself is kind of appealing, a sort of pluripotential risk syndrome. So you are a help seeker, you have something around the SPLIPS, APS, it's a presumed genetic vulnerability and functional decline, and then you are at risk of evolving towards psychosis, but you might also evolve in other directions. So you might have other axis 1 disorder, not in the psychotic spectrum, but nonetheless, you will maintain a certain need of care and a requirement for intensive monitoring. But more interesting is the silent shift. We had a silent shift in the clinical phenotype that we are addressing. So in the Kraepelinian era, we had this sort of dementia precox, which at the beginning it was supposed to be organic, but the concept here is that it's not so much dementia, it's about a sort of form of interhuman stolidity. That's the meaning about it. So you have a Befrenian, you have other variants which are still there, we simply don't diagnose them. And then you have the notion of Blöhlerian schizophrenia, which is more sophisticated, more, let's say, qualifying trait-like anomalies like autism, affective flattening, and so on and so forth. And everything is a little bit more structured around enduring manifestation, out of which the psychotic parts of delusion and hallucination are accidental. So they are not diagnostically central. Because those clinicians thought, well, you can have delusion, but delusion is secondary to a lot of conditions. And you can be a dementia precox subject or a schizophrenic subject without having delusional hallucinations. This is a big revolution, but it was fairly misunderstood in the subsequent diagnostic catalogs. Then we have Schneiderian schizophrenia. Schneiderian schizophrenia is basically what happened after the sort of Second World War, and basically it means that we have a sort of turbocharging of the concept of schizophrenia from the original trait-like, autistic-like anomalies to the productive part. So, thought broadcasting, thought blocking, thought withdrawal, auditory verbal hallucination, so the classic checklist of the productive symptoms. It's not, and in these symptoms that were considered accidental for the older clinician, the fathers of the concept, they became prominent, not because Schneider was dull. I mean, for Schneider it was very evident that they were, let's say, accessory symptoms, but because they could be much more easily noted, even by general practitioners, they became some sort of rail track for the diagnosis. And because, this concept was defined by Schneider in a book that was supposed to be a didactic guide for GPs. It's true. Clinical psychopathology has a very sort of focused target, and it's a didactic manual. It's not supposed to be a sort of condensation like general psychopathology by Jaspers. And then, I showed you in this sort of slide with the colors and this kind of intestine-like movement of the concept of schizophrenia. Schizophrenia disappeared, and it became a sort of generalistic notion of psychosis, as if we do not have schizophrenias without flamboyant psychotic symptoms. Befrenia is the sort of most evident case, but you can also have schizophrenia simplex. Patients with schizophrenia simplex are still there, they simply get another label. They have not disappeared. They are nominalistically out of our visual field, but they are there. Psychopathology is more or less the same. And we moved basically from a notion which was very much comprehensive and somehow more ecologically descriptive to a notion which is sort of hyper-emphasizing the productive side, so the delusional hallucinatory part of the manifestation. Because of what? Because of reliability, because even a policeman normally recognizes somebody who is delusional or who is hallucinating. That, it seems brutal, but it is exactly like that. Reliability is about that. And then you have the sort of German contribution. So from the AUKUS, we go to AUKUS to the Deutsch AUKUS or EU AUKUS. Kloster-Cotter, who was a scholar of the older guy, which is with the glasses, who is Gerd Huber, who was a student of Schneider, because everything is very genetically driven, even in terms of intellectual history. Well, when Emil Kreppel informed the concept of dementia praecox in 1896, he was well aware that this new disease entity, because at the time it was really new, does not generally start off with the first psychotic manifestation. Because typically the onset of schizophrenia, it's sort of pseudo-depressive symptom, borderline-like presentation, and so on and so forth. And then he was very much influenced by his sort of professor, Gerd Huber, who derived the notion of schizophrenic basic symptoms, because he interviewed 200 patients about what was like to have their daily experience. And he sorted out this notion of basic symptom, which were called basic symptom because at the time they were supposed to be the closest experiential atom before the neurobiological defect. So the closest level in which you, through self-description, can go to characterize your mental state, and after that, it was only the sort of synaptic derailment that was the notion of that. It's a notion of the 50s. Basic symptoms are subclinical, self-experienced disturbances in thought, perception, affect, synesthesis, body, and psychomotricity. So, subtle thought block, being fascinated by perceptual details, have to hyper-monitor yourself when you walk, a sort of subtle feeling of self-reference without malignant intention, but merely the fact that when you're among people, you feel that there is a sort of special attention paid to you, and so on and so forth. And so the EU AUKUS concept is that whereas the sort of AUKUS concept, so attenuated or transient psychotic symptoms, are thought to delineate an advanced prodromal state, at-risk basic symptoms, also known as cognitive perceptive basic symptoms, can occur early in course and even at the beginning of the transition sequence to first-rank symptom. They are now used for that's the sort of synthesis. It's the most updated version, European Psychiatric Association guidance paper. And what you see is that you have the black wave, which is the blips, advanced pre-psychotic state, so transient psychotic symptoms. You are psychotic. It's just that they're transient, so they come and go, but your life is not that good. And then you have the APS, light blue, attenuated psychotic symptom. You can suffer like hell, even if they're just attenuated. Sort of the psychometric part is not so relevant with respect to the quality of life. The quality of life is already embarrassingly degraded since the beginning. Because these people suffer a lot, even if they still have inchoate delusional ideation. So delusional ideation is not there, they are just immersed in perplexity, pre-delusional atmosphere and whatever, and they suffer. And then you have the Cooper-Cogdis, which is this sort of part of the European contribution to the concept, which basically, they are alteration in the stream of consciousness. So they do not saturate any psychotic AUKUS-like criteria, but they somehow already embed the germs for a loss of the feeling of minus of the train of thought, some sort of spatialization of the area of consciousness, and so on and so forth, or sonorization of thought. Sonorization of thought means that you experience your thought as if they have a perceptual quality in the phonetic domain. They are not yet hallucinations. It's just a sort of qualitative change in the way your medium of experience is appearing to you, basically. And this is a synthesis of what happened in these 3 decades. You have the sort of clinician illusion in 1994, the blinkers of the horse, the introduction of this at-risk mental state thing, the European contribution to the AUKUS, which is a little bit more fascinating because this copper and cognition, you can find them in kids. You can evaluate them reliably with appropriate instruments since they are 8 years old, which means that, for example, you can do differential diagnosis of learning disabilities because a lot of learning disabilities of strange behavior at school or distraction, distractibility might be due to undergoing copper and cognition, which is quite something. Because the first level of so-called early intervention is not early at all, it's just timely, appropriate intervention when the person needs it. But this is just an example. I mean, let's say that learning disabilities in developmental years are the equivalent of depression in adult psychiatry, in the sense that you come with depressive cloud of symptoms and you might have whatever. But for many, many years, it was enough to say, okay, I'm depressed, okay, no problems, SSRI, and go with God. That would have been a normal treatment in community mental health because it's cheaper, it's fast, and you can outsource it to the GP. And then the thing that looks like a chromatography is this new McGorry concept about the clinical staging. It's just a sort of idea that you have a gradient of severity. And what they do believe is that you might have attenuated bipolar disorder, attenuated borderline, and this might predict that you become borderline or you become bipolar with the mere homotypic trajectory that they used for the early detection of psychosis. And I still have like 10 minutes, so I'm going to touch on some problematic points about this approach, which can be useful just to relativize it. Again, I think it's a very good antidote when you have a system like it was in Italy 25 years ago, which was completely imprisoned in a sort of reductionistic social psychiatric approach. So there was no mental illness, just social exclusion, and you have to be paternalistic with the patient. And then this culture married with the culture of aziendalism, which means that you have an enterprise, you have to be efficient. So it was a tremendous outflow of psychopharmacological support with basically no care for everyone. And with some sort of, inertia of the fact that we bypassed the asylums era because of Basaglia. So we dissolved the concrete walls of the asylum, but then they became some sort of territorial, let's say, following of the patient. But with this sort of focus on chronicity and not with the sort of with the area of initial help seeking, which is a problem, because chronicity it's partly also a iatrogenic effect of the way you treat the patient. So in this sense, I think that on a sort of global level, the AUKUS approach had very important contribution, especially in areas like Southern Europe and Italy, in which there was a sort of sociological reductionism. At the same time, the concept is very primitive. The AUKUS concept is very primitive, so it's not helpful for psychotherapy. It's not helpful beyond a certain level of sophistication of the treating plan. But on an institutional level, it can be quite useful. Anyhow, there is a big bias. All this research, all this evidence, it's about who develops or do not develop psychotic symptoms, delusion and hallucination. You can have frank negative symptoms, you will not be considered as somebody who transits to psychosis. We all know that the most problematic patients are those who have enduring negative symptoms, even at the beginning, because that's the problem, you don't have tools. It's quite plausible that you can manage with the positive symptoms with the available psychopharmacological arsenal. There's almost nothing for the negative symptom, despite what pharmaceutical firms tell you. So there is a total neglect of other outcomes than transition to psychosis. And they are the majority, because in the best case scenario, transition to psychosis happens in 2 years in 1 out of 3. The other 2 out of 3, usually, very few of them go back without any further need of care. Most of them would sort of remain in this fluctuating APS state, which is, as I told you, it has the same risk of suicidality as the first episode of psychosis, and we know it by the literature, so it's not that, let's say, peaceful condition. And there are others that develop different former Axis 1 syndrome, so bipolar, depression, OCD, and so on and so forth. So it's not a very good outcome anyhow. And then there is a huge group which remains in this at-risk state, but with 20 milligrams of olanzapine. And they're not counted as transition to psychosis, but they are treated as first episode psychosis. All of this, it's a bias in the literature. Why? Because most of the authors have stopped seeing patients when the concept started, so 30 years ago. And then we have the other problem that the concept is a tautology. So you predict rain by the first drops. You predict psychosis because you have sporadic psychotic symptoms. It's not that genial, but it works, at least in 1 out of 3 patients. And yes, this is a quote by Joseph Parnas that Nadia evoked at the beginning of the presentation. He's this, I think it's the major expert in psychopathology that is currently alive in Europe, or at least in southern Scandinavia, and somebody who has made a real contribution to the field. So his critique is that basically the early detection approach has a sort of tremendous blind spot, which is exactly those conditions within the schizophrenia spectrum, and they are quite some, because they were the basis of Kraepelin and Bloyer description, and they're still there, and they are young, so they came up to child-adolescent psychiatry normally. They are without hallucination and without delusions. So they almost never get caught in the high-risk approach, or if they get, they enter by the back door, which is the presumed genetic vulnerability and functional decline if they have some relative who is already under treatment, or otherwise they do not enter this area. So they are not visible in the literature, they are not visible in the so-called risk calculators, and they are anyhow in need of care, so they come in the real services. Then this is a sort of mirror image of that. We took one of the most popular meta-analyses of Usarpoli, who is one of the big bibliometric champions of the field. This is interesting because he discovered with this meta-analysis that those who have a BLIPS are quicker to get psychosis than those who have an APS, who are quicker than those who have functional decline and schizotropy, which is obvious because it is implicit in this categorization that there are some who are closer to the psychosis threshold, because BLIPS, it's just the intermittent psychosis, but the symptoms have the psychotic intensity. But this was a sort of epoch-changing meta-analysis in the field which showed simply the implication of the definition. So we took the studies that were inside it, one by one, and we discovered that out of 32, 24 studies, so the 72%, reported prescription of antipsychotic at follow-up. But they did not identify it as an outcome. 7 out of 24, so the 20% of the included subject were already under antipsychotic therapy in inception. So, you know, one thing is you get, as they claim, well, everyone is treated with quetiapine for insomnia. I'm skeptical about that. But still, this is the defense line. But if you have an antipsychotic in somebody who is assessment for high risk of psychosis, don't you think that it was prescribed for some reason? Then, if you don't report it, that's a problem of transparency. It's not transparency in the meta-analysis, it's transparency in the literature. It means that no referees have even thought about the point. That's quite dramatic because this paper, they didn't come out in a local parochial journal. They come out in big, let's say, influential journals. And then we found that 11 studies, only 11 studies out of 33, so 1/3, allowed the extraction of both transition to psychosis in the AUKUS sense, so high scores on the CARMS or on psychotic symptoms, and those who were not transitioned but had antipsychotic therapy. Again, the authors did not thematize that an antipsychotic therapy in somebody who is followed for psychosis has a sort of clinical value. So if you accumulate the total transition to psychosis, including the sort of AUKUS transition, so the psychometric one, and those who started without antipsychotic and then got an antipsychotic being at high risk, you have 3 times more cases. So in the literature, we completely lose those who are included as clinical high risk, and after 3-4 months, they get antipsychotic. They are considered as non-transitioned. And it's not considered as an equivalent of psychosis, even if in the original Melbourne concept, as I showed you, the notion of psychosis in the AUKUS has the psychometric corner, but they also say, well, it's the threshold at which everyone would start a neuroleptic treatment in community mental health. That has completely got forgotten in 30 years. And that's my last slide, which is about another form of transition. So when you transition from being a clinical case to schizophrenia. And we did that with an instrument which is called the Eri-Rayos checklist. So it's something like 12, 14 items, super fast, German. They used that in Milan. And the data were collected for different purposes. So, we are sure that there was no bias in the collection. What we found out is that the clinical caseness for all the help seeker was described by the presence of dysphoria in European sense, so irritability and nervousness and tension, and social withdrawal. All the patients had that. But those who would have had a high risk of schizophrenia had some specific change in subjective experience. So this is a proxy for Copper and Cogdis, or self-disorder in Parnasse sense, and also paranoid autocentrism, which means self-reference, so a change in the field of lived space and experiencing. So and this, I think, is much more interesting because at the end of the day, we're not so much into defining those who will get flamboyant delusional hallucination. We want to get those who are at risk of schizophrenia in a broad sense, because those are long-lasting, enduring partners often in the therapeutic journey, and they need it. And that's sort of this last slide. I think that's the real frontier of early detection, and it's the focus on transgenerational risk factors from many viewpoints, from the psychopathological level of attachment to more sophisticated interaction aspects. But, this is a little bit more interesting approach to, let's say, preventive and appropriate timely detection of risk. Thank you very much.